Hi students, we are going to talk about induction of labor. So what do you mean by induction of labor? See, induction means you are starting a process, right? So suppose you have to go somewhere on your car. So the first thing what you're going to do is you're going to start your car. You are going to ignite the engine, right? With the help of a key. And that is exactly what is induction of labor also. Induction of labor means just now the uterus is absolutely quiet. It is in a quiescent stage. We are starting the process of labor, right? We are starting contractions in a quiescent uterus. On the other hand, once your car engine is ignited, now what you do, if you want to increase the speed of your car, what you do, you put your foot on the accelerator, right? So when you have to increase the speed, that is what you do, that is what is called as augmentation. Right? So here, because, if the uterus is already contracting, but it is the contractions are not adequate. The progress of labor is not adequate. In that case, when I want to increase the speed of the labor, then I say that I'm going to augment labor. So augmentation means the uterus is already contracting. You are increasing the speed or you are accelerating the process of the labor, right? Induction means that there are no contractions in the uterus. You are initiating contractions in the uterus, right? So induction of labor and spontaneous labor are not the same thing. That is also one thing which you have to understand. Spontaneous labor means that the uterus by itself initiates the process of labor. Induction of labor means that the uterus hasn't initiated the process of labor. I have given certain medicines or I have, done something so that the uterus starts contracting. So when you do something so that the uterus starts contracting, that is induction of labor. When uterus automatically goes into labor, that is what is spontaneous labor, right? Now, what are the indications for induction of labor? See, throughout OBS, at so many places we have done that we have to induce labor, we have to induce labor. So I am telling you all the indications at one place and the timing at which induction is done for all those indications at one place. So in PIH, when there was mild preeclampsia, at what time do you induce labor? You induce labor at 37 weeks of pregnancy. In case of severe preeclampsia, you induce labor at 34 weeks of pregnancy. And in case of eclampsia or in case of HELLP syndrome, you initiate labor immediately. The moment patient throws convulsion or the moment you make a diagnosis of HELLP syndrome, you will induce labor, right? What is premature rupture of membranes? Premature rupture of membranes is when membranes rupture after 37 weeks, but before the process of labor begins. Before the process of labor begins. That is what is premature rupture of membranes. Now, in premature rupture of membranes, when do you induce labor? In premature rupture of membranes, you induce labor immediately. But if it is a case of preterm premature rupture of membranes, preterm premature rupture of membranes means when membranes are ruptured at less than 37 weeks, right? Then when do you induce labor? Think and tell me. It was at 34 weeks. In a post-term pregnancy, when do you induce labor? In a post-term pregnancy, you induce labor immediately. Why? Because post-term means that the pregnancy is more than equal to 42 weeks. So you are going to induce labor immediately. In abruptio placenta, when you induce labor, in abruptio placenta, the time interval between delivery and the onset of abruptio is the one which determines whether the patient is going to have DIC or not. So in a case of abruptio, we have to shorten this time interval, right? So In a case of abruptio, you immediately deliver the baby and immediately start the process of labor. So that is immediate induction of labor is done. Similarly, in chorioamnionitis, you go for immediate induction of labor the moment you make a diagnosis of chorioamnionitis. In case of oligohydramnios, in most of the cases, you do induction of labor at 36 weeks. If there is oligohydramnios plus IUGR, then you do an induction of labor at 34 weeks. In gestational diabetes, the induction of labor is done not before 39 weeks, so more than equal to 39 weeks. In case of RH isoimmunization, in RH isoimmunization, if there is severe anemia, and how do you detect severe anemia in an RH isoimmunization patient? By doing a peak systolic velocity of middle cerebral artery. So if peak systolic velocity in middle cerebral artery, it is more than 1.5 multiple of meridian, that means there is severe anemia, and that means you have to terminate pregnancy at 34 weeks. But just in case the peak systolic velocity is less than 1.5 MOM, or if the critical titer, the indirect Coombs test was positive, but the critical titer is less than 1:16, in that case, you have to terminate pregnancy at 37 weeks. Right? In an RH negative female, if indirect Coombs test is coming out to be negative, right? It is not positive. So here indirect Coombs test was positive, but the antibody titer was less than 1:16. If in an RH negative female, indirect Coombs test is negative, then at what time are you going to terminate her pregnancy? In that case, I'm going to terminate her pregnancy at 40 weeks. That means I will not let her go beyond her EDD. Why? Because once she crosses her EDD, the chances of feto-maternal transfusion, they will increase, right? So, this is, the various timings at which you have to induce labor in various conditions. This is one table which is very, very important. Please go through this table very carefully and, make a note of it and stick it on your, in your room somewhere, so that multiple times you can have a look at this table. And when you have a look at this table, one question from this table will definitely be asked in any of the exams which you are going to give. Right? Now, for induction of labor, see, I told you that when we were doing labor, I told you before labor pains begin, there are certain things which are going to happen before the labor pain begins. And what were those certain things? One of it was that the cervix ripens, the cervix softens, right? So this means if I have to induce labor pains, I also have to be sure that the cervix is ready for labor, right? So I have to check the status of cervix before I induce labor. And how am I going to see that the cervix is fit for delivery or not? That I'm going to check by doing a Bishop score. Right? So before you start inducing labor, make sure that the cervix is ready for delivery. And that you are going to do by, seeing a score which is called as Bishop score. In Bishop score, there are 5 parameters which you have to check. And the mnemonic for these parameters is Delhi Police Employed Special Commandos. Right? Where D stands for dilatation of the cervix. P stands for position of the cervix. E stands for effacement of the cervix. S stands for station of fetal head. And C stands for consistency of the cervix. Consistency of the cervix. Right? So this is Bishop score. Nowadays we have modified Bishop score. In modified Bishop score, there is just one difference. And this is that E, effacement of cervix, has been replaced by length of cervix. So instead of effacement of cervix, we have the length of cervix in modified Bishop score. So the mnemonic for modified Bishop score becomes Delhi Police Left Special Commandos. right? Now, to each of these parameters, a score is given, and the score could be ranging from 0 to 2 in some parameters and from 0 to 3 in certain other parameters, right? And please remember that scoring of Bishop score is very, very important. Every detail of Bishop score is important because in AIIMS, what they had done was they had given a clinical scenario where you had to, calculate the Bishop score and give the answer, right? So let us see how Bishop score is calculated. See, over here, all of you know, look here, that normally there is an angle which is present between vagina and cervix, and there is an angle which is present between the cervix and uterus. So this is how normally how uterus, cervix and vagina are present in the body, right? So there is an angle, if this my hand is vagina, there is an angle between vagina and cervix, and if this part is uterus, you can see there is an angle between cervix and uterus also. The angle which is present between a vagina and cervix, that is called as angle of anteversion, and the angle which is present between cervix and uterus, that is called as angle of anteflexion. So normally uterus, cervix and vagina, they are placed like this. That means the uterus is anteverted and anteflexed. Now when uterus is anteverted, see the relationship between cervix and vagina. Cervix normally it lies towards the posterior side of vagina, right? But when the process of labor has to happen, gradually what happens is that cervix aligns itself along the axis of vagina. Normally, cervix is towards the posterior part of the vagina. So, it is posteriorly placed in comparison to vagina. But for the process of labor to happen, the cervix, it aligns itself along the angle of vagina and it becomes anterior, right? So anteriorly placed cervix is good or favorable for labor. So first thing what I have to do is, when I am thinking that I'm going to induce labor, I'm going to do a Bishop score, and in Bishop score, I'm going to do a per vaginal examination and I am going to see the position of the cervix. If the position of the cervix is posterior, I will give it a score of 0. If it is in the middle, I will give it a score of 1, and if it is anterior, I will give it a score of 2. So anterior means it is a favorable position, right? Number 2, I'm going to check the consistency of the cervix. If consistency of the cervix is firm, again, I'm going to give a score of 0. If consistency is medium, I'm going to give a score of 1. And if the cervix is soft, I will give it a score of 2. Right? So this was easy. Position and consistency, position of the cervix and consistency. Right? In position of the cervix and consistency, the maximum score which you have to give is 2. Now you are going to assess the dilatation of the cervix. Right? All of you know that a fully dilated cervix is 10 centimeters, right? So if the cervix is closed, it is not dilated at all, I will give it a score of 0. If the dilatation is 1 to 2 centimeters, I will give it a score of 1. If the dilatation is 3 to 4 centimeters, I will give it a score of 2. And if it is more than equal to 5 centimeters, I will give it a score of 3. So in case of dilatation of cervix, the maximum score which you can give is 3. If it is not dilated, 0, 1 to 2 centimeters dilated, 1. Then it is 3 to 4 centimeters dilated, you give a score of 2. And if it is 5 or more dilated, 5 centimeters or more than that dilated, then you will give a score of 3. Please remember that dilatation is the most important parameter in Bishop score. After dilatation, I'm going to look at the effacement of the cervix. And I explained to you when I was talking to you about labor that how do you know that the cervix is effaced. So look here again. My hands are the uterus. My arms over here are the uterus. And my hands over here, they are the cervix. right? So normally this is the entire length of the cervix, right? And the normal length of the cervix during pregnancy is 4 to 5 centimeters, right? And this over here, my arms, they are the uterus. So dilatation means that the cervix is dilating. This is what is dilatation, right? And what is effacement? Effacement is taking up of the cervix, right? So effacement means that now the cervix is going to become a part of the uterus. So this is what is effacement. Now the cervix has become a part of the uterus. So this action is effacement. This action is dilatation, right? So I am going to see how much is the cervix effaced. And always effacement has to be, it has to be mentioned in percentage. If you can feel only half of the length of the cervix, then you say the cervix is 50% effaced, right? So for effacement, I want all of you to remember it like this: 30, 50, 70, 80. Right? So just remember it like this: 30, 50, 70, 80. If cervix is up till 30% effaced, you will give a score of 0. If it is 40 to 50, obviously till if 30 was 0, then it will be only 40 to 50 here. So if it is 40 to 50% effaced, you will give a score of 1. If it is 60 to 70, you will give a score of 2. If it is more than equal to 80% effaced, you will give a score of 3. So you don't have to remember the range, just remember it like this: 30, 50, 70, 80, and your person and your, purpose will be solved. 0, 1, 2, and 3. Clear to all of you? Okay. The next thing what we have to do is we have to look at the station of the fetal head. All of you know what is the station of the fetal head? Station of the fetal head is the relationship of the leading point of the fetal head with respect to the ischial spine. And we know that from pelvic brim to the ischial spine, there is 5 centimeters, and that is why we have stations from -5 coming up till 0. Ischial spine is 0 station. And from ischial spine to the pelvic outlet, again the distance is 5 centimeters. So we have station from 0 to +5. If the head of the baby is above the level of ischial spine, that is minus station. If it is below the level of ischial spine, that is plus station. And how many centimeters it is away from ischial spine, that is the number, right? So if the head of the baby is below the level of ischial spine, that means engagement has already happened, because engagement means that it should be at the level of ischial spine, right? So if you are getting any, number which is in positive below the level of ischial spine, so it could be +1, it could be +2, +3, +4, +5. No matter what is the station, but it is below the level of ischial spine, then I'm going to give it a score of 3. If the head of the baby is at the level of ischial spine, that is 0 station or near to it, that is -1 station, I'm going to give it a score of 2. If the head of the baby is at -2 station, I'm going to give it a score of 1. But if it is above that, then I am going to give it a score of 0, right? So that you don't get confused, please draw that diagram here also. This is ischial spine. This is +1, +2, +3, +4, and +5. This is 0. This is -1, -2, -3, -4, -5. Right? So if the head of the baby is in any of the plus stations, you are going to give a score of 3. Right? If it is between 0 and -1, you are going to give a score of 2. If it is -2, you will give a score of 1. Right? So if the station is -2, you will give a score of 1. And if it is above that, you will give a score of 0. So -3 or anything above -3 is a score of 0. Clear to all of you? Right. Now, by doing this, we have covered all the 5 parameters, and we have seen that 2 of the parameters, the maximum score was going up till 2. So 2 plus 2 is 4. And in rest of the 3 parameters, the score is going up till 3. So 4 plus 9 is 13. So maximum Bishop score which a female can have is 13. Right? Now, if the score of a patient is more than equal to 9, that means it's a very, very good score and it has maximum success of induction of labor. But if score is less than equal to 5, right? So if it is less than or equal to 5, then that is a bad score or a poor score, and that means first you have to make the cervix ready for labor. In other words, first you have to ripen the cervix. Now, but don't get confused. Sometimes it will be written that score less than equal to 5, a score less than equal to 5 or score less than 6 are one and the same thing. So whether I say score is less than 6, then it's a poor score, or whether I say score is less than equal to 5, it's a poor score. That's one and the same thing. Clear to all of you? So this is what is Bishop score. In modified Bishop score, I told you that the effacement has been replaced by the length of the cervix. Right? So if the length of the cervix is more than 4 centimeters, is it a good thing or bad thing? It is a bad thing, because as the labor progresses, what happens to the length of the cervix? So as the labor is going to progress, as the cervix is going to dilate, the length of the cervix should decrease. So if you are getting a length more than 4 centimeters, that means it's a bad thing, right? And the score you are going to give is 0. If it is between 2 to 4, then a score of 1. 1 to 2 is a score of 2, and less than 1 is a score of 3. So if the cervix is less than 1 centimeters, then you have to give a score of 3. If it is 1 to 2 centimeters, then you have to give a score of 2. If it is 2 to 4 centimeters, you have to give a score of 1. And if it is more than 4, you have to give a score of 0. Right? Now, what is the difference between Bishop score and modified Bishop score is that Bishop score is the one which is done more commonly, because effacement is something which can be assessed clinically. Right? Length of the cervix has to be assessed by ultrasound. So for modified Bishop score, I will have to do an ultrasound to know the length of the cervix. Right? That is why most commonly done is a Bishop score and not a modified Bishop score. But yes, the most accurate one is a modified Bishop score. Right? So a modified Bishop score is done with the help of ultrasound. Bishop score is done clinically. That is why Bishop score is more clinically done, most commonly done, and more accurate is modified Bishop score. Right? Because you are seeing the length of the cervix with the help of ultrasound. So this is the more accurate one. Clear? Now let us do these examples. This was a question which had come in AIIMS May 2016. A primigravida came to labor room at 40 weeks plus 5 days gestation for induction of labor. On per vaginal examination, her cervix is 1 centimeters dilated. Right? So tell me, what score are you going to give her for dilatation? For dilatation, I said if the cervix is not dilated, you will give a score of 0. If it is 1 centimeters dilated, 1 to 2 centimeters dilated, a score of 1. Then 3 to 4 centimeters dilated, a score of 2. And more than equal to 5 centimeters dilated, a score of 3. So here it is 1 centimeter dilated. I'm going to give a score of 1. Now they are saying the cervix is 30% effaced. For effacement, I told you to remember 30, 50, 70, 80. 30 is 0 score, right? So I'm going to give a score of 0. Vertex is at -1 station. So I told you if vertex is at positive stations, you have to give a score of 3. If it is at 0 or -1, you have to give a score of 2. If it is -2, you have to give a score of 1. And if it is 3 and above, you have to give a score of 0. So here it is -1, so I have to give a score of 2. Then the cervix is soft. When the cervix is soft, you give a score of 2. And it is posterior. When it is posterior, you have to give a score of 0. Right? So now add it. 1 plus 2 plus 2, that is 5. So what is the modified Bishop score for this lady? The Bishop score is 5. Right? Clear to all of you? It shouldn't be modified Bishop score because they have given effacement. It should be a Bishop score. Clear to all of you? Okay. Question number 2. This is a practice question for all of you. Cervix is 3 centimeters dilated. Tell me, what will be the score for the dilatation which you are going to give? So the score for dilatation will be 2. So if it is not dilated, it is a score of 0. 1 to 2, it is a score of 1. 3 to 4, it is a score of 2. So I'm going to give a score of 2. Because the cervix is soft, I'm going to give a score of 2. Because the cervix is anterior, again, I'm going to give a score of 2. The 50% effaced, so 30, 50. Here it is 0, here it is 1. So I am going to give a score of 1. The station of the fetal head is 0 station. For 0 station, what is the score which you have to give? For 0 station, the score which you have to give is 2. Right? For 0 and -1, you have to give a score of 2. Now add it up. 2 plus 2 plus 2 plus 2, that is 8, and 1 is 9. So this is a cervix which is very good for induction of labor, and the chances of success of induction of labor will be very high if the score is 9 or more than 9. Right? Now, what are the drugs which you are going to use for induction of labor? The first or the most commonly used drugs for induction of labor are the prostaglandins. They are the best drugs for induction of labor. In prostaglandins, we have got 2 options. One is PGE1 and the other is PGE2. PGE1 is Misoprost. The dose of Misoprost which you have to give for induction of labor is 25 micrograms per vaginally. This dose you have to repeat 4 hourly till the time the contractions don't begin, and maximum you can give up till 6 doses. Please remember that for prevention of PPH, that is for active management of 3rd stage of labor, the dose of Misoprost which you were giving was 600 micrograms. And for treatment of PPH, you were giving 800 micrograms. For induction of labor, you are giving 25 micrograms. Right? Then next you can use PGE2, that is dinoproston. Dinoproston is commonly available in labor rooms in the form of Serviprim gel. Now this gel, it has to be given intracervically, and Serviprim gel, it comes in a preloaded manner. So this is 0.5 milligrams of the gel which you have to give intracervically. You can repeat Serviprim gel after 6 hours, and maximum you can give up till 4 doses, right? So you can use either of these 2 methods to induce labor. Not only these methods induce labor, they can also ripen the cervix simultaneously, right? So the best drugs for induction of labor are prostaglandins. The only one thing which we have to remember is that in patients with previous history of cesarean section, prostaglandins are not used. But that does not mean that in previous cesarean section patients you cannot induce labor. Right? You can induce labor. The method which you are going to use, I'm also going to tell you. But please don't say that induction of labor is contraindicated in previous cesarean patients. That's a wrong statement. So there are 2 statements which are incorrect and which so many times we read in so many books. But these are incorrect statements. Induction of labor is not contraindicated in heart disease patients. Please remember that. And induction of labor is not contraindicated in previous cesarean patients. Yes, prostaglandins are contraindicated as inducing agents in previous cesarean section patients, right? Now, this is dinoproston. It is generally available in the form of this Serviprim. And Serviprim, as I told you, it has got 0.5 mg of dinoproston and it has to be inserted intracervically. And after every 6 hours, you have to repeat it. And the maximum dose which you are going to give is 4 doses. These days, we also have a slow release, formulation of dinoproston. So this is called as Servidel. Servidel, it has got 10 milligrams of dinoproston. And this is a pocket, in this pocket, you have 10 milligrams of dinoproston, and this over here is the thread for easy insertion and removal. And this Servidel, it has to be, put in the posterior vaginal fornix. When you place it in the posterior vaginal fornix, the dinoproston is going to slowly infuse from there. And it has to be removed after 12 hours, or you can remove it earlier if the contractions begin. Right? So after every 6 hours, you won't have to put a Serviprim gel. Here we have a long release formulation of dinoproston in the form of Servidel these days. Right? Then the other drug which we can use for induction of labor is an anti-progesterone drug, that is mifepristone or RU486. The dose of mifepristone which is used for inducing labor, that is the same as the one which is used for medical abortions, and that is 200 milligrams per vaginally. Then you can use oxytocin. Please remember that oxytocin is used not only for augmenting labor, oxytocin can also be used for inducing labor, right? Apart from these drugs, these pharmacological methods, we have certain mechanical methods for inducing labor. One of the mechanical methods for inducing labor is Foley's induction. Now, in Foley's induction, what we do is we take a Foley's catheter, we put it inside the uterus, and then we, fill its bulb with 30 to 50 ml of normal saline. And then we pull the bulb down up till the level of the internal os, and we let it remain there, right? This is also called as transcervical balloon catheter. You can call it as Foley's induction or a transcervical balloon catheter. Now, in this case, there is one more thing what you can do. Once you have put the Foley's and you have, inflated its bulb, you can infuse more of normal saline, and the more normal saline which you are going to infuse, it is going to come out from the bulb and it is going to go into the extra amniotic space. So that is what is called as extra amniotic saline infusion. Right? But the most commonly used is simply Foley's induction, in which you have to put a Foley's catheter in the uterus. You have to inflate its bulb by 30 to 50 ml of normal saline, and then you have to pull it a little so that it rests at the level of internal os. Right? Now, this is the best method for inducing labor in patients with previous cesarean section. What is this going to do? This, balloon catheter, it is going to stretch the internal os, and when it is going to stretch the internal os, that is the process which is going to initiate labor, right? Then you can go for stripping of membranes. Now, this is the only OPD method for inducing labor. So, if you have a patient who's approaching term, what you can do is, while you are doing a per vaginal examination, you can just sweep your fingers. You will see your gynae residents doing it so many times. You don't have to rupture the membranes. You just have to sweep your fingers. Now, when you sweep your fingers, right, the membranes, they get stretched and they release prostaglandins. And it is this prostaglandin which is going to cause the induction of labor, right? Apart from that, you can use hygroscopic dilators. Hygroscopic dilators, they are better used for bringing about abortions. They are not generally used for induction of labor, right? So in mechanical method, we have Foley's catheterization or Foley's catheter for induction of labor. We have this method where we put our fingers in the cervix and we just sweep it around the membranes, right? We stretch and sweep the membranes. And we have hygroscopic dilators. Although hygroscopic dilators like laminaria tent, they are better for bringing about abortion and they are generally not used for inducing labor. Have you understood all the methods for inducing labor? Now, the methods which are used for augmenting labor. So these are all the methods for inducing labor. Now, I also have to tell you the methods for augmenting labor, but before that, let us list down the conditions where induction of labor is contraindicated. Please remember that all those conditions where vaginal delivery is contraindicated, induction of labor would be contraindicated, right? So suppose if there is a severe CPD. In severe CPD, vaginal delivery is contraindicated, so induction of labor is contraindicated. In case of contracted pelvis, in case of transverse lie, bro presentation, or in face if there is a mento-posterior position. In case of fetal distress or non-reassuring fetal heart rate. So in case of fetal distress, again vaginal delivery is contraindicated. You have to do a cesarean section, so induction of labor is contraindicated. In case of placenta previa, in case you have done a classical cesarean section in the previous pregnancy, or if you have done previous 3 LSCS, right? Earlier it was said that previous 2 LSCS are contraindications for induction of labor. Now it is said that previous 3 LSCS, right? If suppose there is a female who has history of previous 2 LSCS, you can allow vaginal delivery if her pelvis is adequate. So that is why induction of labor is not contraindicated in previous 2 LSCS. In previous 3 LSCS, I will not allow vaginal delivery even if her pelvis is adequate. So previous 3 LSCS is a contraindication for induction of labor. As far as classical cesarean section is concerned, as far as previous hysterotomy scar and previous myomectomy scars are concerned, again they are contraindications for trying vaginal delivery. Now because they are contraindications for trying vaginal delivery, that is why induction of labor is contraindicated. Active genital herpes infection is also a contraindication for induction of labor, right? Because in active genital herpes infection, you go for cesarean section. Clear to all of you? Now, let's talk about the drugs which are used for augmenting labor. Now, the drugs which are used for augmenting labor, you know it is oxytocin, and everything what I wanted to tell you about oxytocin, I have already told you in the chapter on PPH. The next method for augmentation of labor is artificial rupture of membranes. In artificial rupture of membranes, what you do? In artificial rupture of membranes, you rupture the membranes deliberately. And you do it with the help of an instrument which is called as Cocker's forceps. So this over here is an image of Cocker's forceps. In a Cocker's forceps, how are you going to identify it? There will be one tooth on one side and there will be 2 teeth on the other side. Right? So, and there will be serrations, you know, present over here. Right? That is how you identify Cocker's forceps. Again, I am repeating that everything what I want you to know about instruments in obs and gynae, I have covered it in a separate video, which is there by the name of Instruments in Obs and Gynae on the Marrow's YouTube channel. Right? So artificial rupture of membranes, you are doing the rupture with the help of an instrument that is called as Cocker's forceps. In private hospitals these days, we are using amnicots to rupture the membrane. Amnicots are small finger gloves which are available, and these finger gloves, they have got a pointed tip. right? So they have a pointed tip, and with the help of these pointed tips, we rupture the membranes. Now, what is the advantage of artificial rupture of membranes? The advantage is when the membranes are ruptured, prostaglandins are released, especially PGE2, and that is going to increase uterine contractions, number one. Number two, when the membranes are ruptured, amniotic fluid is going to come out, and you can look at the color of the amniotic fluid to see whether fetal distress is present or not. Because if the color is green, that means there is fetal distress. Right? So suppose you are doing, you are listening to fetal heart sounds. You do not have the facility for doing CTG monitoring during labor. And while you were auscultating fetal heart sounds, it appeared to you as if there was a dip in the fetal heart rate. Right? The fetal heart rate suddenly dipped. Now, in order to be sure that yes, there is fetal distress, what you can do is you can rupture the membranes, and you can take a sterile pad, and you can allow the amniotic fluid to fall onto that sterile pad. And then you can look at the color of the pad. If the color of the pad, if there is a greenish tint on the pad, that means there was a fetal distress, and that means you should take up the patient for cesarean section. So if you have to detect fetal distress during labor, that is also one of the indications for doing artificial rupture of membranes. The third indication for doing artificial rupture of membranes is in patients of abruptio placenta. In patients of abruptio placenta, when you do artificial rupture of membranes, the contractions begin, and because the contractions begin in the uterus, the bleeding decreases, right? So in patients of abruptio, we go for artificial rupture of membranes. Right? Now, what is the risk of artificial rupture of membranes? See, suppose the head of the baby was not fixed, the head was free floating, and you did an artificial rupture of membranes, what can happen? The cord of the baby can come out, right? So it can lead to cord prolapse. That is why, unless and until the head of the baby is fixed, we do not do artificial rupture of membranes. If the head of the baby is free floating, artificial rupture of membranes is contraindicated. Number one. Number two, what are these membranes doing? These membranes, they are acting as a barrier between the head of the fetus and between the vagina. So they are not allowing the fetus to come in contact with mother's vagina. In other words, these membranes are preventing any kind of infection from reaching the fetus. So once you do artificial rupture of membranes, there are increased chances of infection. And yes, if you are not careful while doing artificial rupture of membranes, you can also cause trauma or injury to the fetal head. So these are the risks which are associated with artificial rupture of membranes. The other name for artificial rupture of membrane is amniotomy. Now, in what conditions is artificial rupture of membranes to be avoided, or artificial rupture of membranes is contraindicated? So, number one, in a free floating head, artificial rupture of membrane is contraindicated because there are increased chances of cord prolapse. Number two, in case of HIV positive mother. If mother is HIV positive, I am not going to do artificial rupture of membranes because it will increase the chances of transmission of HIV from the mother to the fetus. Similarly, if mother has active genital herpes infection, I am not going to do this. And number four is in intrauterine death of the fetus, right? So these are the conditions in which artificial rupture of membranes is contraindicated or it should be avoided. Now, in case of polyhydramnios, what happens? In case of polyhydramnios, when you do artificial rupture of membranes, the entire amniotic fluid comes down suddenly. And because entire amniotic fluid comes out suddenly, the size of the uterus suddenly shrinks. And because the size of the uterus suddenly shrinks, the placenta which was attached to the uterus, that gets detached and that leads to abruptio. So if you are doing artificial rupture of membranes in polyhydramnios, that can cause abruptio. That is why in a patient of polyhydramnios, we do not do artificial rupture of membranes. What we do is a special technique called as controlled rupture of membranes. Controlled rupture of membranes. Now, what is controlled rupture of membranes? See, sometimes you must have experienced this, that when you are sitting in the emergency, a male patient would come and with the complaint of urinary retention, right? So they have elderly patients, they have BPH and they come to you with complaint of urinary retention. Then what do? Obviously, you are going to put a Foley's catheter. Now, if the bladder was over distended, and the moment you put Foley's catheter, the urine comes out suddenly. And because the urine comes out suddenly, the bladder gets compressed. And because the bladder gets compressed, that leads to hematuria, right? Because of the sudden decompression, right? Now, in order to avoid that, your seniors tell you that you have to empty the bladder slowly with the help of Foley's catheter. And how do you empty the bladder slowly? What you do is you take the urobag and you hang it at a higher level. When you hang the urobag at a higher level, then gradually the urine is going to come out and gradually the size of the bladder would decrease, and that would prevent hematuria from happening. Same principle we have to adopt in polyhydramnios patients. In polyhydramnios patients, we do not have to suddenly rupture the membranes. What we do is we take a needle and a syringe, we guard the needle with our fingers and we take it inside the mother's vagina, and with the tip of this needle, we make a very small hole on the membrane. Now, when you make a very small hole on the membrane, the amniotic fluid is going to, trickle from that small hole, and slowly the size of the uterus will decrease and there won't be any abruptio. This is called as controlled rupture of membranes. So in case of polyhydramnios, we do not do artificial rupture of membranes. We do go for a controlled rupture of membranes. But see, this is so easily said than done. The membranes are very tensed in polyhydramnios. So many times when you are taking the, needle and you are guarding it with your finger only the membrane gets ruptured. Right? Now what to do? Now there are increased chances of abruptio, but the increased chances of abruptio will only be there if the entire amniotic fluid comes out suddenly. So what I am going to do this, if something like this happens, with my gloved hand, I am going to take a sterile pad and I am going to put it on the mother's outlet, vulval outlet. Right? And with my hand, I will not allow the amniotic fluid to come out suddenly. With the slicing movement of my hand, I will, controlled movements of my hand, I will allow only amniotic fluid to come out in a controlled manner and not come out suddenly. Right? So many times in labor room, this is going to happen with you. You are going to go for controlled rupture of membranes, but the membranes will suddenly rupture. In that case, don't panic. Just pick up a sanitary pad and close the mouth of the mother's vulva with your own hand. Right? And do not allow the amniotic fluid to come out suddenly. Let the amniotic fluid come out gradually with controlled movements of your hand. Right? So, this is how we go for augmentation of labor. So, there are two methods for augmentation of labor, oxytocin and artificial rupture of membrane. The other methods which I told you, the sweeping of the membranes, then Foley's catheterization, prostaglandins, oxytocin, then your mifepristone, all these were methods for induction of labor. Induction of labor is a very important topic, especially Bishop score, right? So there are 3 total scores in OBS which you have to remember. Number 1 is Bishop score. Number 2 is biophysical score. And number 3 is APGAR score. Out of these 3 scores, generally one of them is asked in the exams, right? So these 3 scores, I want all of you on a piece of paper, write down on a sheet of paper rather, write down all these 3 scores and put it up near your study table, right? So that is all what you have to know in induction of labor. Keep studying. Take care.